Hello everyone, this is another video for lecture 7 and we are going to talk about different types of control conditions that are often used in experimental studies in general. This is not just related to randomized experiments, the same issues relate to quasi-experiments. So what are the different control conditions that researchers are using in these randomized controlled trials? One of the most maybe intuitive control conditions that you can think about is having no treatment at all in the control group. So the treatment group gets the treatment and the control group gets no treatment at all. This is a way to assess the effectiveness or the efficacy of the whole treatment package. So the treatment package as a whole, both its active components and its more general component of the treatment. So the active ingredient of the treatment in this case is of course measured, but it is hard to disentangle it from other more general effects of being treated. So for example, people we know from thousands and thousands of studies that simply giving someone a treatment on its own has a beneficial effect. So people expect to get better if they are treated. And this response expectancy, in other words, the placebo effect, can generate positive outcomes on its own without any active chemical or psychological ingredient at all, just simply the expectancy. The therapeutic allegiance with the therapist or the doctor can also have beneficial effects. It is a good feeling that someone is caring for us, that someone is dedicated or invested in getting us cured, and this simply this companionship and allegiance with the person has positive benefits in terms of both psychological and even physiological outcomes. And also that we are spending time, energy, and attention on getting cured. It also in itself is beneficial for us. So it focuses on our attention on getting better and get us better. And we are using only a no treatment control condition paired up with a treatment condition, then we are assessing this whole treatment package, both active and non-active ingredients of the study, or specific and I should say specific and non-specific ingredients of the treatment together. And there are also some limitations in using a no treatment control condition. It might be unethical to withhold treatment from people, especially if that treatment is known to be effective or is highly expected to be effective. And also it can increase the risk for some construct validity threats. For example, resentful demoralization can easily manifest in a group that is told that they are specifically not going to get treated. So they will not get any treatment at all. It can lead to resentful demonization, or it can also go the other direction. It could evoke compensatory rivalry, where these people would do everything in their power to beat the treatment group to kind of compensate for their lack of resources that is provided for them. It could also lead to unintentional or intentional help from the care providers, which is called the compensatory equalization. This is also mentioned in the previous lectures on construct validity threats and in the book, of course. So just using a no treatment control condition can or involves a high risk for all of these threats to construct validity. It may also lead to people seeking other treatments. So people who are sick, who are ill, usually don't just do nothing. They usually seek some sort of help, and if they don't get that help in the clinical trial that we are running, then they will seek help from other sources, and this could lead to them finding some effective treatment and nullifying or decreasing the differences between the control and the treatment group without us being aware of this. So this is another thing to keep in mind when we see a no treatment control condition. There are many alternatives to the no treatment control conditions, and these are also used or more frequently used actually in clinical trials. So, for example, the placebo control condition is often used in medical studies. So this control condition is specifically devised to control for the effect of expectancy or response expectancy, so the placebo effect, but it also has the benefit of people thinking that they are getting the treatment. So these construct validity threats that we have talked about are also less of a risk in this kind of control condition. Using a placebo control condition is less straightforward in psychotherapy studies, and in some authors also argue that it is not even meaningful to use a placebo control condition. So in most of the psychotherapy treatments that we use nowadays, response expectancy is an integral part of the treatment itself. So it is extremely hard to treat a person with CBT, cognitive behavioral therapy, without that person expecting some benefit from the treatment. You might do surgery on someone, and they might get the benefits without the expectancy of the effectiveness. But with the psychotherapy, you need some investment, some motivation from the participant, from the client, especially for therapies like CBT, where you have a lot of homework that the person needs to do at home, and these kinds of investments from the client are kind of conditional on them believing that the treatment will work. Otherwise, they will just simply not do the exercises. So in psychotherapy studies, we very rarely see placebo control conditions, but there are a few cases where they have managed to put some similar thing. Sometimes they are called conditions, where they would use another psychotherapy-like treatment as a control condition. Okay, so moving on, attention control is another kind of control condition. In this control condition, you would have a person, a caregiver, who would devote the same amount of time and attention to the participant or the client as the case in the treatment group, and this way you can control for time and attention devoted to healing, and also to some extent to therapeutic allegiance between the therapist and the client. Another type of control condition would be waitlist control. So attention control requires a lot of resources because you need a therapist in the control group as well. And it is also often problematic in terms of treatment diffusion. So it is very hard for an actual clinical therapist to their therapist tools in a situation when they are working with a person, with an ill person. So it requires a lot of training for them to be able to withhold the treatment while still paying attention and devoting time and energy to the participant. Waitlist control means that people are told in the control group that they will get the treatment after the control period. This way, you can prevent the resentful demoralization, for example, of people, because they are not simply told that you are not going to get the treatment at all. They are told that you just have to wait a little bit and then you would get the treatment. This is also more ethical this way. So you're not simply withholding the treatment from them, you're just maybe delaying the treatment. It is more acceptable often to the participants as well. Another way of using control conditions is if the control condition is using another treatment. If this is an already established treatment that is used as a control condition to a new experimental treatment, you can establish that not only that the treatment, the experimental treatment is more effective, but it would be also sometimes a desirable outcome to see that the new experimental treatment is at least as good as the previous treatment, the already established treatment. Especially if the new experimental treatment utilizes less resources or is applicable to a wider group of patients. So the treatment as usual control condition is an kind of a direct and more ethical alternative to the no treatment control condition. So the treatment as usual control would mean that people in the control group would get the usual treatment. So the treatment, they would get the same treatment as if they had this illness and entered the clinic before the experimental treatment was discovered or was tested. And this way you are providing treatment to people, and also you are again counteracting these construct validity threats that we have talked about. Another benefit is that you avoid this kind of uncontrolled treatment seeking by the participants. So you, in this case, you know what kind of treatment they received, which can be a good benefit. And again, you could establish that the new experimental treatment that you are testing in the treatment group is at least as good as if people got treatment as usual. which could be a desirable outcome. Okay, and the last kind of design related to control groups is the dismantling design that I wanted to mention. In this case, you are the conditions in the study are two different variants of the same treatment. So, for would not use hypnotic induction, for example, only use the same but without induces. And for the treatment group or the other group, you would give the full hypnotherapy intervention. So this way you can kind of dismantle the different active or specific ingredients of the treatment itself, and you can assess what are the benefits or the added value to the effectiveness of the different elements of the treatment. So in the next video, we are going to talk about factorial design.